Hello, Dr. O'Keefe, Dr. Press-Hedrick. Today we will be presenting our findings on the impact of communication, media, and politics on influenza. We will explore how these factors contribute to vaccine hesitancy and acceptance throughout history, as well as compare and contrast these findings to the current COVID-19 pandemic. Our group is Reese, Buie,
Lauren Mobley,
and Kate Polaski.
Let's get started. What is vaccine hesitancy? It is defined as a delay in acceptance or refusal of vaccines despite availability of vaccination services. It is an important issue that has spanned across history ever since the first vaccine was developed. Many people may be hesitant to receive a vaccine due to misinformation, mistrust, and fear. Throughout our presentation, we will discuss how vaccine hesitancy and acceptance have been influenced by communication, media, and politics. Communication has played a major role in the acceptance of vaccination. The World Health Organization Working Group considers that communication is more a tool than a determinant. This is due to conflicting information that may cause vaccine hesitancy. Although vaccines are safe and effective ways to prevent disease, there are many controversies surrounding the dangers of vaccination. These suspicions about the safety of vaccines have long been a contribution to the public's rejection of vaccines. The spread of false information breeds mistrust among the public and is intensified by traditional and new media, like social media apps. Poor and inadequate communication promotes vaccine hesitancy and negatively impacts vaccine uptake. When comparing vaccine acceptance for influenza and pandemic diseases, we found a study in 2011 that investigated the factors that influence vaccine acceptance. The study analyzed the acceptance of the H1N1 vaccine after the 2009 swine flu pandemic, which was in its post-pandemic phase. The results of the study showed that overestimating the side effects of the influenza vaccination caused reduced vaccine acceptance. Other factors that weaken vaccine acceptance included poor communication. Most health institutions did not properly communicate their inability to predict how severe the H1N1 virus would be or its spread, as well as the availability of vaccines or their effectiveness. When comparing these factors to the current COVID-19 pandemic, there is little evidence available to determine whether these same factors influence vaccine acceptance for the COVID-19 vaccine. In recent years, vaccine hesitancy has been amplified by anti-vax groups, conspiracy theories, myth and misperceptions, questions about the speed of vaccine development, and long-term side effects. A Kaiser Family Foundation poll from August 2020 found that only 42% of participants would get the COVID-19 vaccine if it was approved before the 2020 US presidential elections. This high percentage of vaccine hesitancy can be contributed to participants believing that socioeconomic factors and pressures led to a rushed approval of the COVID-19 vaccine, which may impact its safety and efficacy. We will delve more into these factors throughout the presentation.
Media has also affected the acceptance of both the recent COVID-19 vaccine and the influenza vaccine. For the COVID-19 vaccine to provide herd immunity, it is estimated that at least 55% of the population, and maybe as high as 85% of the population, need to be vaccinated. However, the media has affected the amount of people willing to be vaccinated. False information about the pandemic and the vaccine has widely circulated on many social media platforms. This has caused large-scale vaccine rejection, which threatens needed herd immunity. When surveyed in June of 2020, 34.2% of Americans said they would accept the COVID-19 vaccine. However, due to this false information being spread through the media, more recent polling has shown significant falls in willingness to accept the vaccine across all demographics. A study was conducted in which respondents were exposed to misinformation relating to the COVID-19 vaccine or showed factual information about COVID-19 vaccines. The responses first provided their intent to receive a vaccine before and after being exposed to this information. Before exposure, 42.5% of individuals in the US reported that they would definitely accept a vaccine, and 15% said they would definitely not receive the vaccine. The remaining respondents were unsure. The treatment of misinformation caused a decrease by 6.4 percentage points for how many individuals would definitely take the vaccine. This misinformation includes that the vaccine will alter DNA, it can cause infertility, and that it can make individuals who get the vaccine sick with COVID-19. Media has also had an effect on the influenza vaccine. The Spanish flu pandemic occurred in 1918 through 1919. However, a vaccine for the flu was not developed until the 1940s. The first influenza vaccine was tried without consent, first on psychiatric patients at 2 different hospitals. This was at the onset of the flu season of 1942. Towards the start of the flu season in 1943 and 44, the vaccine was tested on participants of the Army Specialized Training Program, once again without informed consent. In 1944, the Surgeon General gave orders to inoculate every member of the U.S. Army in the fall of 1945. The vaccine was not approved for civilians until 1946. This vaccine was created by Thomas Francis and Jonas Salk, and while some findings were published in the Science magazine, the media tended to cover the polio vaccine, also created by Salk shortly after the production of the influenza vaccine, as opposed to covering the influenza vaccine. However, upon the onset of the swine flu, there was a heavy push for the vaccine, including propaganda such as this poster shown that says, "If you are sick, who will take care of the kids? Get a shot of protection." Media such as this helps push individuals towards getting the vaccine, contrary to the misinformation provided about the COVID-19 vaccine that pushes individuals away from becoming vaccinated. Overall, the key differences between media coverage of these vaccines are that there was little media coverage at the onset of the influenza vaccine, while there's widespread media coverage of the COVID-19 vaccine. There was also a push for the influenza vaccine during the swine flu, while the misinformation spread about the COVID-19 vaccine causes extended hesitancy towards the vaccine. Finally, the onset of the influenza vaccine, there was a push towards another vaccine for polio, whereas now the sole focus is on the COVID-19 vaccine.
In the 1970s, a small outbreak of the swine flu had the potential to explode into a pandemic, the likes of which had not been seen since the 1918 Spanish flu. Despite significant medical progress since that time, medical companies did not begin mass-producing vaccines for swine flu until the federal government put policies into place which would shield them from lawsuits should harm come to someone because of the vaccine. When the government agreed, the idea that the vaccine could put people at risk caused mass panic, and pushback from citizens caused President Gerald Ford's vaccination program to be shut down. This gives us an example of how political decisions can impact the effectiveness of vaccination programs. With the modern-day flu, yearly vaccination is encouraged but not required by the American government. Conservative politicians are more likely to oppose mandatory vaccination, citing the ideals of personal freedoms, aka the government cannot interfere with their rights to choose what actions they take with their bodies, concerns about growing size and the influence of government, as well as religious reasons for abstaining from vaccination. Liberal politicians have a track record of supporting mandatory vaccination laws, or at least encouraging everyone to vaccinate, citing the idea of personal responsibility for public health, meaning if you don't get vaccinated, you could get other people sick, which interferes with those people's rights to health and bodily autonomy. The COVID-19 pandemic has occurred during a time of unprecedented ease and speed of international communication. Scientific communities across the globe have been working to treat patients as well as develop the vaccine, sharing information amongst themselves. This level of cooperation in the worldwide scientific and political community has not always existed. It came into being largely due to heightened geopolitical tensions of the Cold War in regards to development of space travel and the production of nuclear weapons. Much of the leadership in terms of regulating international response and guidelines for the COVID vaccine have come from the World Health Organization, which was founded by the United Nations in 1948. Both of these aspects of international political and scientific cooperation did not exist during the Spanish flu epidemic, nor during the creation and distribution of the first influenza vaccine in the mid-1940s. Another political issue involved with COVID-19 is the aftereffects of colonialism and imperialism, which continue to affect the abilities of former colonial powers to have their political stability and capital necessary to fund vaccine research, purchase doses, and distribute them to their citizens. Former imperial powers, known more widely as first world countries, are being prioritized in vaccine distribution due to wealth and international influence, despite the fact that second and third world countries may have a greater legitimate need for vaccines. With smaller and less funded medical infrastructure, COVID-19 can be more deadly in lower income countries, but global politics prevents them from being the first to receive the well-needed vaccine doses. Some programs do exist to administer doses to those countries, but most world governments are more concerned with vaccinating their own citizenry first. Additionally, in many first world countries such as the United States and the United Kingdom, vaccination has become a political issue rather than a medical one. And many citizens have chosen to listen to the leaders of their political parties over medical officials. In these countries where politicians have tried to make the COVID-19 vaccine into a political point that's up for debate rather than a medical necessity, deaths have reached some of the highest levels worldwide. A key difference between the vaccine efforts for influenza and COVID-19 in regard to politics is that now, during COVID, the international medical community is far more interrelated and cooperative than it was during the production of the first influenza vaccine. The first influenza vaccine was developed in around 1938, but not approved for civilians until 1946, 8 years later. The globalization that has occurred since then means that the medical community could share knowledge across countries and political lines, leading to the development, approval, and rollout of the COVID-19 vaccine in under a year. One commonality between the vaccine efforts of influenza and COVID is that wealthier, more industrialized first world countries have more available capital to invest in production and distribution of vaccines. In both cases, this leads to a phenomenon known as vaccine sovereignty, where wealth and power, rather than need, determine vaccine access worldwide. We see similar patterns of political debate about mandatory vaccination with COVID that we've seen throughout history with the flu vaccine, but modern arguments against mandatory vaccination of COVID center more around the personal choice ideal than they do potential health repercussions of the vaccine itself, like they did with the early flu vaccine. In conclusion, the factors of communication, media, and politics have affected the vaccine campaigns for many viruses over time, including those of influenza and COVID-19. Here are our sources. Thank you so much for listening to our presentation.